Let's get right into the high-yield pediatric decision logic for Step 2 CK. We are zeroing in on infant nutrition, normal neonatal physiology, and the specific pathologic deviations you are practically guaranteed to see on the exam. Here is our clinical map for this explainer. We'll be moving through infant nutrition and breastfeeding, neonatal weight loss, pediatric dehydration, neonatal hyperbilirubinemia, pediatric anemias, and finally, neonatal scalp swellings. Section 1. Infant nutrition and breastfeeding.
So let's look at the timeline. From birth, exclusive breastfeeding is the gold standard. Once a baby hits 6 months, that's when we introduce pureed foods. And you hold off entirely on cow's milk until they are at least 1 year old. Knowing this exact timeline is absolutely crucial because introducing cow's milk or solid foods too early is a major setup for highly testable pathology later down the line.
Now let's talk mechanics and supplementation. Newborns need to feed every 2 to 3 hours. That means a busy schedule of about 8 to 12 feeds per day in that first month for at least 10 to 20 minutes per breast. As a quick aside, by 4 to 6 months, term infants usually don't need those overnight feeds anymore for metabolic needs. For supplements, there are hard rules you have to know. All exclusively breastfed infants absolutely require vitamin D supplementation, no exceptions. If the infant is premature, they need iron supplementation before 6 months because they missed out on that massive third trimester maternal iron transfer. And if the mother follows a strict vegan or vegetarian diet, that infant requires vitamin B12 to prevent neurologic deficits and macrocytic anemia.
In clinical practice, you are constantly weighing the systemic benefits of breastfeeding against the absolute contraindications. For the infant, breast milk massively improves immunity and drops the risk of things like otitis media and respiratory illnesses. For the mom, it speeds up uterine involution and lowers the risk of breast and ovarian cancer, but you have to catch the strict contraindications. Active untreated TB, maternal HIV in developed settings where safe formula is readily available, herpetic breast lesions, active street drug abuse, and infant galactosemia. Notably, though, being on medication-assisted treatment for opioid use disorder, like methadone, is perfectly compatible with breastfeeding as long as the patient is enrolled, adherent, and not using recreational drugs. Section 2. Neonatal weight loss guidelines. Okay, healthy infants can normally lose up to 7% of their birth weight in the first 5 days of life. This freaks parents out, but it's totally normal physiology. They're just excreting excess fluid they acquired in utero. The hard clinical milestone you need to look for is that they must regain that birth weight by age 2 weeks. A really handy clinical proxy for hydration during this time is the wet diaper rule. In the first week, the number of daily wet diapers should roughly equal the baby's age in days. After week 1, you want to see more than 6 wet diapers a day. But what if that weight loss crosses the 10% threshold, or they start showing actual signs of dehydration? You've got to intervene. First step, assess for breastfeeding complications right away. Is there a poor latch? Is there a tongue tie? Next, you move to daily weight checks. If maternal supply is truly inadequate, you strongly consider formula supplementation. And if they are looking severely depleted, you need to check serum electrolytes and glucose to rule out any dangerous metabolic derangements. Section 3. Pediatric dehydration management.
When a kid comes in dehydrated, your physical exam literally dictates the severity grade and your next steps. Mild dehydration is about a 3 to 5% volume loss, and honestly, they might have minimal findings. Moderate dehydration hits that 6 to 9% mark. Here, you'll see dry mucous membranes, decreased skin turgor, tachycardia, irritability, and a delayed capillary refill of about 2 to 3 seconds. Severe dehydration, 10 to 15% volume loss, is a straight-up emergency. You're going to see cool, clammy skin, a sunken fontanelle, profound lethargy, a capillary refill well over 3 seconds, and potential hypotension or shock. Recognizing those physical signs is critical because it creates a massive divergence in your treatment plan. For mild to moderate dehydration, if the kid can keep fluids down, you use oral rehydration. It works beautifully. But the second you cross into moderate to severe territory or you see any signs of shock, oral fluids won't cut it. You immediately push a 20 milliliter per kilogram isotonic IV bolus using normal saline or lactated ringers. Write that dose down. 20 mils per kilogram is the magic number.
Section 4. Neonatal hyperbilirubinemia.
Telling the 2 common forms of indirect hyperbilirubinemia apart is a classic exam scenario. It's all about the timing. Lactation failure jaundice happens in the first week of life. The baby just isn't getting enough milk, which slows down bowel movements, ramps up enteropetic circulation, and causes obvious signs of dehydration. Breast milk jaundice is totally different. It peaks after the first week. The infant is feeding great, completely well hydrated, but high levels of an enzyme called beta-glucuronidase in the breast milk are deconjugating intestinal bilirubin and sending it right back into the blood. For management, it's all about the clinical threshold. With breast milk jaundice, you just reassure the parents and keep breastfeeding. It usually resolves by 3 months of age. For lactation failure jaundice, you need to fix the intake, increase feed frequency, increase duration, and consider formula if needed. Now, regardless of the cause, if that bilirubin is rising rapidly, your initial move is non-UV phototherapy. And in the most extreme cases where bilirubin is threatening to cause kernicters in the brain, you escalate straight to a partial exchange transfusion.
Section 5, Pediatric Anemia and Polycythemia.
The underlying mechanism behind early infant anemia tells you exactly what to do next. Physiologic anemia of infancy is a totally normal process seen in term infants around 2 to 3 months of age. When that baby takes their first breaths, the sudden spike in tissue oxygenation downregulates erythropoietin production. Hemoglobin drops temporarily, but the reticulocyte count stays low to normal. You just reassure them. Contrast this with anemia of prematurity. This hits much earlier, the drop in hemoglobin is far more severe, and it's usually made worse by a shorter red blood cell lifespan and constant NICU blood draws. As infants get older, the risks shift entirely to their diet. Iron deficiency anemia is classic in toddlers drinking more than 24 ounces of cow's milk a day, simply because cow's milk has virtually no iron. Other red flags include prematurity, delayed introduction of pureed foods, or lead exposure. When you look at the labs, you're going to see a hemoglobin under 11, a low mean corpuscular volume, and a high red blood cell distribution width. And here's the kicker for the exam. Your next best step is not an expensive lab workup. It is an empiric trial of iron supplementation to see if they improve.
Section 6, Neonatal Scalp Swellings.
Differentiating birth trauma to the scalp is all about understanding the anatomical tissue layers. Caput succedaneum is basically just subcutaneous edema. Because it sits way up above the periosteum, it easily crosses the skull's suture lines and feels soft and boggy on exam. A cephalohematoma, on the other hand, is a subperiosteal bleed. Since the periosteum is tightly tethered to the edges of the individual skull bones, this firm swelling absolutely will not cross suture line.
Now consider this classic clinical vignette. You're examining a newborn in the nursery. You notice a fluctuant scalp swelling that freely crosses suture lines, but uniquely, it keeps expanding for days after delivery. Soon, the infant starts showing signs of tachycardia and profound pallor. Based on those anatomical borders and the alarming systemic signs, what specific pathology are you dealing with here?
You are looking at a subgaleal hemorrhage. The bleeding here happens in the loose areolar tissue space trapped between the periosteum and the galea aponeurotica. Because this massive space is completely unrestricted by suture lines, the blood loss into it can be absolutely profound, leading directly to severe hemorrhagic shock. Spotting this specific type of swelling isn't just an exercise in anatomy, recognizing it immediately is the difference between a routine newborn exam and a life-saving intervention.